Oh, there he is. He was below the ledge. He's ready to go. Hello, good afternoon. Welcome. Good to see you all. These are the faithful few right here. Made to look larger by the reconfiguration of the seats. But we value every one of you, and thanks for coming. I think it's a meaningful talk that we've got this afternoon. It's going to be a little shorter than usual. I actually have something I want to run by this elite group that will take a few minutes, and so I've asked the docs here who are presenting to give me 10 or 15 minutes at the end that I can talk to you about a new service that we're expecting to get started out here, and that I think will be well received. But it's first time that I've been able to talk about it. Presenting today, as you know, we have two of our residents who are working out here. It has always been monthly. It's had to go to every 6 weeks now. Hope that changes in the future. I like monthly, actually. But the two that are presenting today and are with us working this 2 week block have been here before. They're familiar faces to many of you, and so they keep coming. So their time comes up again to give a talk, and so I appreciate what they've planned. We're talking about antibiotic stewardship. Have you heard that as a medical term before? Stewardship to me was the money they want me to give to the church, right? But this is another aspect of stewardship, and it's in our changing understanding of human health. Our use of antibiotics is changing. You're a pretty savvy group, you have some sense of that, but they're going to give us some examples and what it means and why it's important. So I hope you'll find that good. So Dr. Joseph Kuhn is our upperclassman, third-year resident that you'll recognize, and Dr. Hayes Osborne, who in the last group, half the people in the audience knew half his family because they grew up in Fayetteville and they're prominent professionals in the community. But with that understated introduction, I'll turn it over to the group and we'll hear what they have to say.
Hi, my name is Dr. Kuhn, and I guess we can go and get started. So I'll be doing the first portion of this presentation. Thank you. Aha. Okay, so introduction to antibiotics. So what are antibiotics? Antibiotics are antimicrobial drugs effective against bacteria. So we also have, in contrast to antivirals, for example, which are antimicrobial drugs effective against viruses. These are typically grouped, so there's multiple ways to group these. They're typically grouped either according to which organisms they act on or by which manner they exert their effects. So below that are some examples of how we group antibiotics in the medical field. So we either say they're narrow spectrum or they're broad spectrum. So narrow spectrum would be something that only acts on certain bacteria. Broad spectrum would be something that acts on multiple groups of bacteria, large families of bacteria, or multiple families. Generally, we prefer narrow spectrum instead of broad spectrum because broad spectrum are more likely to produce antibiotic resistance, and we'll get more into that later. Bactericidal versus bacteriostatic. So bactericidal are antibiotics that kill bacteria. Bacteriostatic are antibiotics that stop the growth of bacteria. It doesn't actually kill the bacteria, but it stops the growth of it. And then these are different kinds of antibiotics. So beta-lactams, it's a grouping based on functional status, the way that the antibiotic works. So beta-lactams, aminoglycosides, macrolides, tetracyclines, glycopeptides, all of that. And then this is the next line here is grouping based on the kinds of bacteria they act on. So antibiotics can act on gram negatives, they can act on gram positives, they can act on atypical bacteria or anti-pseudomonal They can have anti-pseudomonal effects, meaning that they act against Pseudomonas, and etc. So going back up to narrow spectrum versus broad spectrum. So a narrow spectrum antibiotic may be good only against gram-positives, for example, whereas a broad spectrum might be good against gram-positives, gram-negatives, and Pseudomonas. Okay, so generally we would use broad spectrum if we're not really sure what we're treating, and narrow spectrum if we have a good idea of what we're wanting to target specifically. And of course, antibiotics are only useful in treating bacterial infections. And they can sometimes be used in parasitic infections as well, but they have no role in the treatment of viral infections. So, introduction to antibiotic resistance. The widespread use of antibiotics without justifiable cause has led to the development of drug-resistant bacteria. Two examples of that are MRSA, which I've probably heard about, methicillin-resistant Staph aureus. So that's as opposed to methicillin-susceptible Staph aureus, so MSSA or MRSA. So MRSA is a type of Staph aureus, which is a bacteria that is resistant to the drug methicillin, which is similar to penicillin. So it's resistant to methicillin, so it's MRSA. So there are some Staph aureus that we can use methicillin, and that would be an MSSA. So that's an example of a drug that, through the use of penicillins, Staph aureus, some Staph aureus strains have developed resistance to those drugs, and so we can no longer use simple penicillins. Instead, we have to use something like vancomycin, which is much stronger. And then ESBL stands for extended spectrum beta lactamase. So the E. coli is a bacteria that you've probably heard about a lot. So you can have pan-susceptible E. coli, which means it's E. coli that's susceptible to a lot of different kinds of antibiotics. And then you can also have ESBL E. coli, which means really the only effective agents are like carbapenems, which are some of our strongest antibiotics. And the reason that ESBL E. coli has come about is, again, through the overprescribing of antibiotics. And as those antibiotics are spread among a large population, like the United States or the world, over time and within populations, the bacteria that commonly infect people within those populations develop resistance. So even though you may not have been exposed to the antibiotic, if your population has, you may develop an antibiotic-resistant bug. Okay. And then, so how are helpful ways to prevent further antibiotic resistance? So these are methods we use to prevent it. So correct dosing of antibiotic therapies. It's not helpful if we underdose an antibiotic, because then you're not acting adequately to treat the infection. Instead, you may just be exposing the bacteria to a little bit of the antibiotic that it can develop resistance to, that it can mutate and develop resistance to, instead of actually killing it. So we want to use a correct dosing. So if something, whenever you're prescribed antibiotic, it might be a once daily dosing or twice daily or 4 times daily. Sometimes I might get a question of, hey, is it okay if I just take this once a day instead of twice a day? I don't like the way it makes me feel. You can't do that. If it's prescribed twice a day, you have to take it twice a day in order to maintain a steady concentration that will kill that bacteria. Correct, and then the other thing is correct duration of antibiotic therapies, not too long or too short. So it's another thing is sometimes people will say, hey, this antibiotic gave me diarrhea. I don't like the way it makes me feel. Is it okay if I just stop it a couple days early? No, it's not appropriate. Now, maybe we can switch you to another antibiotic that maybe won't give you that side effect, but you need to complete the course for, if you have a UTI and standard duration of treatment is 5 days, you need to be on treatment for 5 days. You can't just stop it prematurely, because again, you may not have killed all those bacteria, and the ones that are still existing, they may develop resistance to the antibiotic they were exposed to. Adherence to prescribed treatment, so just taking it the way that it's prescribed. Minimizing the use of antibiotics when not indicated. So again, not prescribing antibiotics for every bronchitis episode or every runny nose. And using pathogen-directed antibiotic selection when appropriate or when possible. So we will commonly gather, especially in the hospital, we do that more in the hospital than in the clinic. We will gather blood cultures, or we'll take urine cultures. We do that here in our clinic. And we'll culture that, and we'll see what grows. Is it E. coli? Is it staph? What is it? And then in the lab, they're able to expose that particular bug that they get from your blood. If they grow something, they can expose it to drugs and see, hey, does this drug kill this bacteria or not? And we'll actually get a susceptibility chart with like 10 different antibiotics listed. And it'll say, hey, this particular E. coli is resistant to these 3 drugs, but it's susceptible to these 5 drugs, and you can choose one of the susceptible ones. So if we get that kind of a report, we try to choose the antibiotic that is that bacteria is susceptible to. And so that's pathogen directed. So there's another idea called empiric therapy. So that is what it's more commonly used in the clinic than in the hospital setting, because sometimes we have fewer resources in the clinic, or we need to do something. It's a Friday, and we can't get blood cultures and get the result that day. It'll take a couple of days to get that data back, but you're sick, so we need to treat you with something. So what do we do in those times when we don't have data as to what bacteria is growing in your body? How do we treat you? Well, we use an empiric therapy approach, which means that we say, well, what's most likely to be causing your pneumonia? Well, typically pneumonias are caused by staph or strep, so we'll give you an antibiotic that is effective against those bugs, because empirically we know that it should be effective for your disease. And then we can test it as well and find out a few days later, hey, was this a good selection or not, and change it if it's not. But sometimes we have to start treatment before we get all that data back. So urinary tract infections are infections of the urinary tract, either the bladder, urethra, the ureters, the kidneys. Common pathogens that infect the urinary tract are E. coli, Klebsiella, Proteus, Enterococcus, Candida, which is a fungus. Women are definitely more likely to get UTIs than men, and that's just based on anatomy. Typical symptoms that you have in a UTI: increased urinary frequency, urgency, burning with urination. Some concerning features associated with UTI would be fever, chills, flank pain, nausea, vomiting. Those could be indications that you've developed a complicated urinary tract infection, or maybe an infection of the kidneys called pyelonephritis. And urinary tract infections stand in opposition to something known as asymptomatic bacteriuria. So urinary tract infections, you always have symptoms. If you don't have symptoms, it's not a UTI. But if you have asymptomatic bacteria, that is something that comes about through when we study your urine. If we take a urine sample and we look at it to see, hey, is there blood, or there white blood cells, is there bacteria in it? Sometimes it'll pop positive as saying, hey, there's bacteria in this person's urine. And we ask you, hey, do you have any symptoms? And they'll say, no, I have no symptoms at all. So that's asymptomatic bacteria. There's bacteria that's in your urine, but it's not causing any symptoms. There's no infection going on there. We almost never treat that except for certain populations, and I'll get into that. So how can we classify UTIs? Classify them based on clinical presentation. So asymptomatic bacteria, which is what I was just talking about, bacteria in the urine without symptoms. It's only treated in pregnancy or in patients about to undergo urologic procedures. Concerning features for UTIs, like I talked about, fever, chills, flank pain, nausea, vomiting. And then you can classify UTIs based on location. Is it a lower UTI, meaning that it's infecting the bladder and the urethra, or is it an upper UTI that's infecting the kidneys and the ureters? And how severe is it? Is it uncomplicated, or is it complicated? A complicated UTI, there's those 3 bullets there describe what a complicated UTI would be. So it's a UTI associated with recent urologic instrumentation. So if you recently had a catheter in, or you currently have a catheter and you develop a UTI, that's called a catheter-associated UTI. It's a complicated UTI. Nephrostomy tubes, if you had a cystoscopy, those are all things that if you develop a UTI in association with that would make it a complicated UTI. Also, UTIs in patients with risk factors for poor outcomes. So men, if you're a male and you have UTI, it's complicated just by default. Postmenopausal, that as well would make it a complicated UTI. UTIs in pregnancy, UTIs in the presence of anatomic abnormalities. If you're immune suppressed, if you have diabetes, or if you have kidney failure, severe kidney failure, not just like mild, but severe kidney failure, those would make it complicated. As well as healthcare associated UTIs. So if you develop a UTI while in the hospital, that would make it complicated as well, because the bacteria that exist in the hospital are more antibiotic resistant, and they're more severe, and so that means that it's most likely to be a complicated UTI just because of what you're exposed to there when you developed it. You can also classify a UTIs based on frequency. A recurrent UTI is 3 or more episodes of symptomatic, culture-proven UTI in 1 year. So it's not just, hey, doc, I felt like I may have had a UTI a couple times this year. It's symptoms plus culture proven, where we actually studied your urine, grew it out, and said, yes, this person is growing E. coli in their urine that happens 3 times over the course of a year, then that's recurrent. Or it can also be 2 or more times in 6 months. So you can either do 3 times in 1 year, 2 times in 6 months. That would classify as a recurrent UTI. How do we treat them? All symptomatic UTIs should be treated with an antibiotic strategy. Asymptomatic bacteria should only be treated in patients who have recently undergone urologic procedures or who are pregnant. Recurrent UTIs should also be treated. And there are actually some prevention mechanisms. So we can use antibiotic prophylaxis, weak antibiotics that we give you over a long period of time to help prevent UTIs. There's also things you can do personally without a prescription that can help prevent recurrent UTIs if you suffer from them. And here's some of those things. So there was a meta-analysis, which what's a meta-analysis? A meta-analysis is when a group of researchers go through a database where they look at previous research that's been done, and they compile all that data, and they sort through it, and they say, okay, what is the summarizing information from all these different studies? So a group did a meta-analysis in 2023, so this is pretty new data, on 26 different trials that included over 6,000 patients. And they showed that cranberry products reduced the risk of symptomatic, culture-proven UTIs. However, there was no real agreement on which regimen was the best. So a lot of times people will use cranberries to kind of prevent UTIs. It's something you hear about sometimes, cranberry juice, cranberry tablets. And actually, there's really good evidence that it works. The general recommendation that this group came out with was either an 8-ounce glass of cranberry juice once or twice a day, or cranberry concentrated tablets, 500 milligrams to 1,000 milligrams each day. So that's what they said. You know, the different trials use different dosing, but the group that did the meta-analysis said this is what we would recommend as probably being the best. Also, increased fluid intake, which is Dr. Wright's hobby horse, increased fluid take to 2 to 3 liters of fluid per day could reduce incidence by 50%. It's another really good data, really good study that showed that recently. It was in the last couple of years that came out. Okay, moving to upper respiratory tract infections. So these are infections of the nasal passages and the throat, above the voice box. Almost always viral in origin, but if they don't resolve in about 7 to 10 days, you can consider bacterial causes at that time. General recommendation is conservative management for the first week. So increase fluid intake, Tylenol, decongestants, or if you have the flu or COVID, there's specific therapies we can give you for that. Lower respiratory tract infections, including acute bronchitis, pneumonia. This is an infection of the respiratory tract below the voice box, so the trachea, the lungs. I said most commonly viral in origin. That's true for acute bronchitis, not true for pneumonia. Mostly pneumonias are bacterial. Viral causes will usually resolve in 2 to 3 weeks, and it's important to determine the likely etiology and target therapy to what you think is the causative bacteria there. Acute bronchitis, features of that include cough, fatigue, shortness of breath, runny nose, sore throat, normal vital signs. 90% of these are viral in origin, almost exclusively acute bronchitis. When you come in, hey doc, I've been hacking for a couple of weeks. Almost always, if you have normal vitals, your blood pressure is fine, it's not really low, you're not tachycardic, you're not having a fever. Usually it's viral in origin and it'll resolve in a few weeks without any antibiotics. We can commonly order a chest x-ray to make sure you don't have a pneumonia there. Pneumonia is more scary than acute bronchitis. And pneumonia is normally associated with abnormal vital signs. If there's no resolution in a few weeks, or if there's any concerning vitals, we can investigate further for bacterial causes or just empirically treat you. How do we treat acute bronchitis? Target symptoms, so Mucinex, cough suppressants, Tylenol. And this is an area where until the last few years, antibiotics were overprescribed for this condition. You know, people would come in and say, hey doc, I've been coughing for a few weeks, and you give me something. They prescribe a Z-Pack, give you some azithromycin for 5 days, send you on your way, and that would typically make you feel better. But the thing is that azithromycin is an antibiotic, but also has an anti-inflammatory property. So it's not clear, was it because it was helpful because it was curing a bacterial infection, or because it's just anti-inflammatory because of the nature that in which it works, and it cut down on the inflammatory response in your airway. But this was a condition that was overprescribed antibiotics for, and definitely contribute to antibiotic resistance. However, in patients with underlying COPD that develop bronchitis, those patients are almost always treated with antibiotics from the very beginning, because we know that typically if you have COPD, you're at increased risk for bacterial infection that can cause an exacerbation. If you present with that, if you're hospitalized with that, first line treatment in that situation would be antibiotics.
Hello. All right, and so continuing our thread right along, going into skin infections, it can often be a little bit confusing if you have a new lesion, rash, what have you, and to wonder, is this an infection, is this bacterial, or is this something else entirely? Some of the helpful things to think about is whether it's unilateral, whether it's just on one side. It would be unlikely for something of an infectious process to, by coincidence, ascend up both legs in an equal, symmetric fashion. Some other things that are suggestive that it is warm, red, swollen, and tender, and accompanying symptoms of fever and tachycardia are also suggestive. Whereas things that aren't red and are symmetrically ascending, just color changes, really doesn't point to a bacterial infection generally. And here are some examples of some common sorts of presentations that can look like infections, or maybe kind of raise suspicion for an infection, but in fact won't really be benefited by antibiotics at all. Here you can see kind of what we're talking about, where the one leg is completely normal, the other has swelling, and another sign to consider is that you will have an expanding area of redness that's spreading, as opposed to being more chronic to an area or shrinking over time. For non-infectious processes, it's dependent on what the individual cause may be, and we advise you to consult one of us or a different physician to parse that out. But some general rules of thumb is that reducing swelling is benefited by elevating the legs, physical activity. If it's owed to a rash and dry skin, lotion can be beneficial. And in certain cases, wound care or gout treatment might be necessary. But if you do have a suspicion for an infection, it is important to go ahead and come see a physician. So antibiotics, in addition to the risks associated with developing resistance, a lot of times you'll kind of be faced with this, well, let's have a Z-Pack or antibiotics just to be safe. Just, why not? Why not have the benefit in case there is a bacterial infection? The trouble is that antibiotics, like any drug, isn't just inert. There are side effects to every medication and certain risks associated with them. In the case of antibiotics, you are open to yeast infections, possible rashes, nausea, diarrhea, altered mental status, etc., but those are some common effects. And one that we particularly worry about, especially in a hospital setting, is development of a C. diff infection. It's kind of a unique infection because this is a organism that is native to the GI tract. And what happens is the introduction of antibiotics disturb the balance of native organisms. and without other organisms suppressing the growth of these otherwise pretty mundane, do nothing in your GI tract sort of organisms, they can become pathological, overgrow, and produce very severe diarrhea uh, that can have lethal effects, and ultimately requires a different antibiotic to treat them. And also, as we're learning more and more about how the internal gut biome works and the different things it does, this is kind of a cutting edge area of research as it's being developed. We're finding more and more things that are affected, from neurotransmitters in the brain to obesity later in life, are all impacted by your gut biome. And here's my very alarmist picture to wake everyone up, but there is some importance to it that that these medications, if we misuse them, if we allow resistance to develop in them and we don't have them, then moving forward we won't have them for situations where they're really necessary and really can do a lot to help people in the future for years to come, and really provide better treatment. And as the last little horn to toot, everything comes back to vaccines. It's really important to get your vaccines because these can oftentimes prevent the necessity to use antibiotics in the first place. Not only because it might prevent a bacterial infection from developing or getting severe enough that they require antibiotics, but as we've talked about, most respiratory tract infections start as viral infections. Well, these viral infections reduce the immune system and open the door oftentimes to the development of a bacterial infection, either on top of or short thereafter, as the viral infection is resolving. So by being vaccinated, staying on top of this, you can shorten the duration of an illness, reduce the severity of symptoms, and likely do yourself favors at preventing a development of additional illnesses that you weren't even perhaps vaccinated for. That's all I have.
To a vote, they may want to turn me off anyway. Well, are there questions related to this whole subject of antibiotics? You know, I think in the last couple of decades, the expectation as a patient, even when I'm on the patient side of it, is kind of, well, but what about an antibiotic? We need an antibiotic. But when I first started practice, so 4 decades ago, it was, the antibiotic wasn't the issue, is, are you going to give me a shot? Because now that pill stuff doesn't work. I would argue with patients over this. And then finally, you realize we're still overdoing it. And it's kind of a hard lesson for physicians to learn too, because you've had a certain practice and habit of doing things a certain way, and probably the majority of patients got better, and often after the antibiotic, and so you assume the antibiotic's the reason they got better. Time may have been the reason they got better. We don't always know, but so practice habits change too. Hate to admit, physicians are creatures of habit as well, and so any questions? Yes, ma'am.
I'm concerned about the antibiotic resistance. For instance, I've had to have a lot of dental work, and my physicians and the dentist have me take antibiotics every time I see my dentist. And I'm always afraid it's going to work into resistance.
Fair question. You want to address that?
Yeah, so with dental procedures and what have you, I can't speak at great depth to all the antibiotic research to specific dental procedures. It is something paid to mind that I would say you're right to worry. I would say that the medical community as a whole is a little worried. But generally, if you're being prescribed an antibiotic, it is done so with recommendations that the benefits outweigh the risks, is generally a calculation that is put into recommendations surrounding antibiotics associated with procedures of this form or another.
And especially that would be true in the case of dental practice. It'd be true in patients who have heart murmurs or some type of heart valve dysfunction, because it's so likely that even transient bacteria in the bloodstream could set up infection on a valve, and then you've got something much more major to deal with. So that's one of the few areas, common practices of giving prophylactic antibiotics. There are few, but that's the most common, I think, in dental practice. So good question. Yes, ma'am.
Before they had antibiotics, we were given sulfa drugs. What is the difference between an antibiotic and sulfa drugs?
Well, sulfa drugs is kind of an umbrella category that includes several different types of antibiotics.
Sulfa drugs are antibiotics.
Mm-hmm.
There's more than one kind. So it's a category of antibiotics. Oh, really? Okay. Yeah, that was on the first slide. Right.
Mm-hmm.
Mhm.
Mm-hmm. Mm-hmm.
Oh,
Well, that's what led to the development of the recognition of antibiotics. So tell me again, what did you say an antibiotic is?
Antibiotics generally are of a couple different categories, either contributing to killing, being cidal to bacteria, or bacteriostatic, basically preventing their division.
You're right. There's nothing wrong with what you just said, except that a therapeutic agent meets the definition of an antibiotic in this way. An antibiotic is the product of another living system that can inhibit or kill a second living system.
Mm-hmm.
And that's really the definition. That's why I call it an antibiotic.
Mm-hmm.
And so that's what really makes the difference. May I ask another question?
Mm-hmm.
What is the mechanism in regard to the cranberry juice that helps in protecting against UTIs?
So that's a bit of a topic of debate and discussion. One of the research modalities that are kind of thought about is that it deals with how the microorganisms are able to adhere to the walls of the
Yes.
bladder.
Exactly. It seems to inhibit their ability to attach to the walls of the urinary tract. Yes. And if I may ask another question, what what do you think about this idea of fecal transfer in very difficult cases after antibiotics when the normal flora cannot be restored.
Mm-hmm. Mm-hmm. So for people that don't quite know what we're talking about, yeah, so that is something that has been discussed, wherein stool from one healthy individual can be transferred to another individual's GI tract and introduce bacteria to reestablish a sort of equilibrium. And it is being introduced at several facilities to significant benefit to several individuals. I think it's actually viewed pretty favorably by the infectious disease specialists at Mercy. It is a tough pill to swallow, I think, for most people in more ways than one, but it's definitely an interesting area of research and kind of gets at what we were talking about we don't have a complete understanding of all that goes on with the internal gut biome.
And Helen, just to clarify what we were meaning by sulfa drugs, it I think in shorthand it does kind of misrepresent it by suggesting that all sulfa drugs are antibiotics, but there is a group of antibiotics that are referred to as sulfa drugs, like Bactrim is put in the category of sulfa drug. I mean, maybe it's just shorthand usage, but it's the way it's used.
Sometimes a mistake is made that a medication that functions like an antibiotic will be called an antibiotic, and I think that might be what's happening there. But, you know, penicillin originally was from a mold, and so many of these antibiotics are products, metabolic products of fungi of various kinds. But that leads me to also bring this up that I think is a fascinating idea and maybe will work, and that is now they're beginning to use artificial intelligence to design new drugs, antibiotics, and they're very hopeful that that's going to be successful. I wonder, I got in late, so I don't want to ask you to repeat it, but could you give people, because I think it helps to understand so much of the great information that you gave, in a simple way, what really leads to the development of a drug resistance or antibiotic resistance?
Dr. Kuhn covered that, so maybe you want to go back over that.
So generally, it is there you can get into specifics, and we can talk about some more of that. But first, generally, it is the exposure of a bacteria to a drug in a way that does not kill the drug, but that exposes it to it in a way that is able to develop resistance. So the things that we were talking about earlier that prevent that can prevent antibiotic resistance is correct dosage of an antibiotic. So make sure you're prescribing a dose of antibiotic that can adequately kill or inhibit the growth of the bacteria without just exposing it to it in a way that it allows it to develop resistance. Another thing is adequate duration of therapy, so you don't terminate your therapy too quickly. And also correctly targeting the bug that you think is growing. So if you don't think someone has E. coli, don't treat them for E. coli. You know, so that those are general ways in which we think about preventing antibiotic resistance too.
Well, you're right. What I really had in mind was to have people understand that one of the reasons, if you do not treat adequately, and that there are some organisms which are not eliminated, not killed by the treatment, they then undergo genetic change. It's a type of evolution on the part of that organism. They undergo a genetic change that makes them resistant. So it's a genetic change that's important.
Yeah,
I understand that there's been a new antibiotic developed just very recently. Can you tell us a little bit about it and what it might be good for?
Did you hear anything else about it?
No.
They're kind of developing new antibiotics all the time, but I'm not. Do you know what it is? Do you know?
Med Review has I just got it on recently, and I didn't read the whole thing simply because it's beyond me right now. I've been retired for 30 years, so it's a whole different thing, but it looks like it's going to be a real advantage to work for.
Hopefully it'll be a big advantage without as big a risk of resistance, because the history for a couple of decades back in the 80s and 90s was a new antibiotic comes on board and it's stronger than anything we've had, and so everybody's using it. And it was in the aftermath of that we started realizing how huge the resistance potential is for these supercillins and gorillacillins, as they call them.
Forgive me, this subject just fascinates me. This new antibiotic that Buzz is talking about is effective against some of the gram-negative infections. And gram-negatives have a reputation of being more difficult to treat than the gram-positives. These are just large categories of how we classify bacteria. And it's most interesting, the mechanism is so interesting, and it's completely different from anything that they've ever developed before. So I think you'd be interested in looking it up and finding out how it works.
Yeah, so it's an anti-gram-negative antibiotic. No one's heard a name yet. I'm sorry.
Gram-negative is more difficult to treat anyway.
Absolutely. Is there somebody here?
One thing I wanted to mention in regards to your comment about the gene regulation. So, example of that would be beta-lactams. So, beta-lactams are one of the largest families of antibiotics and includes penicillins, amoxicillin, those things, antibiotics that you're probably very familiar with. And as we've exposed bacteria through decades to some of these antibiotics, some of these bacteria have been able to upregulate gene expression that produces something called a beta-lactamase inhibitor. So beta-lactams target the beta-lactam ring in bacteria, and bacteria have been able to develop a beta-lactamase inhibitor that then breaks down the active ingredient in beta-lactams, so penicillins and amoxicillin. So commonly what we'll do if we think that an individual is at increased risk for having one of these beta-lactamase inhibitor bacterial infections, then we will treat them with a combination drug that includes, if we think they're at risk of having an infection with a bacteria that expresses beta-lactamase, then we will prescribe them with a beta-lactam and a beta-lactamase inhibitor. So it's a drug that inhibits the inhibition of the drug that we're giving. So an example of that would be like Augmentin or tigacycline. So.
Okay. Several years ago, I had a UTI. Went to the doctor, got a prescription, got better, and then a day or two later, I was just totally fatigued. Couldn't wake up, finally had to go to the ER. And they did all kinds of tests and told me I had sepsis. And I always wondered, did the UTI cause the sepsis, or why did I get sepsis, I guess is what I'm asking.
Yes, so UTIs are one of the most common ways that people develop sepsis. So what is sepsis? Sepsis is a clinical scenario in which you have a systemic inflammatory response to an infectious source. there's different ways that we can define what sepsis is. Some of those are going out of vogue and new ones are coming in vogue. There's different scoring systems. One is the SIRS criteria, which uses 4 different criteria. Most of them are clinical, where we can just see you in clinic or just look at you and do a couple physical exam findings and say, hey, I think you're septic or not. And other ones are a little more complicated that require more blood work, and that would be like the SOFA scoring system. And it's just an acronym. So it's not actually like a SOFA, but it's an acronym. But anyways, yeah, so urinary tract infections, if they become severe, are one of the most common ways that people develop sepsis. However, I will say that they're also some of the most easy to recover from sepsis. So if you develop a UTI, urosepsis, UTI-related sepsis, or urosepsis, you might get sick very quickly, but you'll also improve very quickly, thankfully, usually, if you're treated adequately.
Good. Are there other questions? Thank you, guys. Well done. I said I had something else I wanted to discuss with this elite group, because I want your reaction, but also kind of just want to announce it so that there's an anticipation of it. Something I've wanted to procure for this campus for some time is access to someone, a clinician who treats insomnia in the most effective way. If you read any article, especially out of the medical literature on insomnia, and we of course know how epidemic it is, this room is full of people who are older adults, includes all of us except these two. We're pretty susceptible to this. But if you read an article, the conclusion will be, or when it gets down to treatment, it will acknowledge, and this has been true for over a decade, it'll acknowledge the treatment of choice is something called CBTI, which stands for Cognitive Behavioral Therapy for Insomnia. CBT generally is a set of different types of mental health therapy that addresses different sorts of depression or anxiety and other things. It's the most common type of psychotherapy you would encounter if you go to sit down to talk to someone who's a trained ear. And it's a very useful service in itself. CBT for insomnia is a little different. It is, as the name would imply, it does have a psychological basis, but it also has a very strong educational basis, really. So isn't that wonderful? And why haven't we brought that to Butterfield Trail before now? Because, and all the time, and I practiced medicine in Northwest Arkansas for 44 years. And all that time, there's been no practitioner that does that service. Isn't that a shame? Isn't that amazing? Well, there's been one, and she is a clinician, a licensed high-degree social worker at the VA. But if you're not a veteran, she can't treat you. And then I found out 2 weeks ago that she has left the VA and is starting her own practice. And when I called her and talked to her about, what about patient referrals from Butterfield Trail? Absolutely, she would love that. And said, and in fact, unless there's something required about using your own office, I'm sure they would give you space here, which would make it convenient for you and for patients out here. And she loved that part too. And I just wanted to share this with you because usually when you think about what is the treatment of insomnia, it's which pill. It's an argument about which pill is the safest. And quite frankly, I hate to remind us all of this reality is that there's no pill that will help you sleep that doesn't have some risk to it, and then some of them have big risk. So I remember when I was talking to her, we actually had her out here to talk to the staff, and she was very willing to train people, and be a part of that kind of thing. This was a couple of 3 years ago, and it kind of people here were enthusiastic about it, but I think they felt like they didn't have any staff that wasn't already overextended, and so it didn't go anywhere. And I was disappointed. So for the last couple of years, I've just been trying to find someone that would get the training. If they haven't been part of their practice till now, they get the training. It's serious training, but it's not too extended, and it'd be worthwhile if it fit into their practice. Otherwise, haven't been able to find anybody. Just been very discouraging. But I'm very excited about this. And she is very excited about it. Her name is Elsbeth Fast, and I'm just so impressed with her. Actually, I met her by being on a panel for a presentation to medical students a few years ago, and realized what her experience has been. You know, as of that time at the VA, and she'd been treating people through the VA for 4 or 5 years. Do you know what her success rate in curing insomnia? 70%. Now, Helen, how many things have a 70% success rate? Yeah, it is. It's just very exciting to me. And so if you were unlucky enough to be in the 30%, there's no downside to it. I mean, there's no side effects of it like pills when they're unsuccessful. So anyway, I'm just very excited about this. And she was out of town when last week, and is just getting back in town. But I had my last text with her. I had asked her if she'd be willing to give a presentation on this, where you could come just like this to the auditorium, to the performance hall, and hear firsthand and have a chance to ask questions, that kind of thing. She's most happy to do that. So keep your ear to the ground. We'll get the word out when we get that arranged. And my response has been the sooner the better. And I think she'll be well received at Butterfield, don't you think? Something that's that positive. I think that's what she's willing to do, and so we'll try to have that happen in the next few weeks. So wanted to share that with y'all. You're the enthusiastic supporters of what we're doing. And by the way, I've floated it by a few of the important people administratively, and they're all very positive. So I'd be disappointed with any other response, but I wasn't surprised. I'm very pleased they're all excited about it. So I think that would be progress, and I think that would be a great thing for Butterfield. And I said, Elsbeth, you could just point to Butterfield as your success place, you know, unless I miss my bet, you're going to have a few people who'd be willing to be your publicist for a night's sleep, right? I've heard people would do that for one night's sleep. Just give me one good night's sleep. So anyway, we'll have that properly circulated when it's going to happen, but pretty soon. And the reason I'm kind of urgent about it is she's just opening her practice. She's not busy yet, but she'll be busy later. And let's get it on the front end, so on the ground floor. So I thought you'd be interested, pleased, and excited about that. And so just wanted to share it. And these guys were willing to give up their time. You know, so I'm going to carve out 10 or 15 minutes here, and they seem to be very supportive. So thank you again for supporting this, for coming. Even when the meal tables crowd us, it just makes us look busier, doesn't it? Thank you all.